Greetings, everyone. It's a great pleasure to come to you today. And I want to begin by saying that you see, I'm wearing a shirt that says, Never treat a stranger, never kill a friend. And the importance of this, and we try to promote this around the world, is question your patients before you operate on them so you know what their risk factors are so that you can protect them depending on what their various risks are. And don't forget, the risks for surgery are not only the type of procedure, but also the baggage that the patient brings to the emergency room. So that, with that having been said, I'd like to talk about VTE risk after surgery, the role of the Caprini risk assessment model, especially with reference to the cancer patients. I have no disclosures related to this presentation. And the Caprini risk assessment model is the most validated tool in surgical patients with 40 risk factors. And it has been massively validated recently by Thomas Orbanik and Kiri Lobostov in 4.2 million patients from around the world. And what's really important is the Caprini score isn't just a list of risk factors. It also compares the power of the risk factor plus the number. So take a look at patient A, 42-year-old patient with a BMI of 29 and on birth control pills. A score of 3 with 3 risk factors. The second patient is a 76-year-old patient with a history of pulmonary embolus and a past cancer. 3 risk factors, but the Caprini score is 8. So although each of these patients has 3 risk factors, the combination of number of risk factors and their power results in a more accurate estimate of VTE risk compared to a simple list of risk factors alone. You wouldn't give prophylaxis to a person with 3 risk factors with a score of Caprini score of 3, but you better do it for a Caprini score of 8. Now, the Caprini score thresholds vary, and these are based on these 4,200,000 patients. And you can see, originally, Chess said that everybody above 5 was high risk, but we know now that there's a very large group of individuals and over 5, depending on their risk, that have greatly increasing chances of developing cancer with an increasing score, as you can see, all the way up to 47% when the score is over 11 to 12. Now, there's a problem with the VTE after cancer surgery, and 2.3% after oncologic surgery associated with a six-fold increase in mortality. And most VTE events occur after the patients go home from the hospital. And if you take a look here at the percentages, depending on the type of cancer, also will be the incidence of VTE. Cancer guidelines, it's recommended for high-risk patients. Uh, these are patients with pancreatic, liver, biliary, lung, stomach, brain, and esophageal cancer, and moderate risk. You can see here colorectal, ovarian, uterine, bladder, and renal. And then the lower risk are prostate, breast, and head and neck. And pharmacologic prophylaxis was recommended for all cancer patients except for basal and squamous cell skin cancer. And low molecular weight heparin is the preferred prophylactic agent, and using mechanical prophylaxis as an adjunct, especially when pharmacologic prophylaxis is contraindicated. And incidentally, every patient on the operating table, except for certain orthopedic exceptions where you're operating on that leg, should have compression because the operative environment, including anesthesia, is a perfect milieu for the development of thrombosis with all 3 of Virchow's factors present: stasis, hypercoagulability, and vascular damage due to dilatation and stasis. And so pneumatic compression means to be used during the operative procedures and, of course, postoperatively. Taking a look at the various incidents of cancer surgery and the Caprini validation, you can see the cutoffs here in colorectal and There's no question that if you combine D-dimer with the Caprini score, it increases the accuracy. We'll see more about that later, and you can see the other figures here. Esophagectomy, particularly high incidence of cancer, and as well as um, thoracic and GI. This family history is the single most important missing element in histories and physicals, and one of the most powerful risk factors that can lead to a thrombosis. And it's good, it has to be looked at in all three models. And this study from thrombosis hemostasis in 2013 in 183,000 individuals, it showed an elevated familiar VTE risk persisting across degrees of relation, not only first degree, but second degree, third degree, and even sometimes people that live together because they might have common similar lifestyles. And so that study's been ignored in the literature. But then along comes Zoller in 2024 and shows a study in 750,000 patients showing the distinct clusters depending on the uh, degree of family history of association with the patient, first degree, second degree, and so forth. 8 different clusters that are associated with not only venous thromboembolism, but other complications as well. Obesity, diabetes, gout, varicose veins, and arterial thrombosis. Very important. Don't forget VTE family history. Yes, it's fine to talk about thrombophilias, but thrombophilia only 30% of people that have a clot have a positive marker or have been measured. So you've got to have the history of family. Family history is very, very important. Another thing that's often overlooked, and this is the only risk assessment that has this um, question in it, and it's very, very important. Patients that have had unexplained stillborns, recurrent spontaneous abortions, premature birth with toxemia, growth restricted infant, these patients may carry one of three important antiphospholipid antibody genes: lupus anticoagulant, anticardiolipin antibodies, or beta 2 glycoprotein. If they have all three, then the chance is very high that they will develop a venous thrombosis. And don't forget, sometimes after the pregnant years in a woman, sometimes these defects may persist. And so you've got to always ask these questions. And if they're positive with this history, test them. Antiphospholipid antibodies is a simple test. There is no question that the Caprini score needs more work, failed to moderate discrimination, and some of the patients, and this study is interesting, it says that 70% of colorectal patients did not have a high Caprini score. But in my opinion, if you go back and look at those studies, you'll find that a lot of Caprini score studies, they don't look at all 40 factors. So when they don't look at all of those factors and the obstetrical factors, and the family history is most often not looked at, then of course you're not going to get an accurate Caprini score. And that's really very important. Now, adding the D-dimer, as you can see here in this table, it shows that that will increase the incidence, increase the accuracy of the Caprini score. The Carana score versus the Caprini score, of course, you can see the differences here. One of the things I'd like to see done going forward is to test the Caprini score in ambulatory surgery patients, because I don't think you can, I don't think it's a stretch to consider that 40 factors, when asked in these patients, will be better than 5 variables. But that's an area for improvement for some of my younger investigators to thoroughly flush out. So don't forget dynamic scoring. There's an initial assessment when the patient comes into the hospital, but following that, it's important as the patient goes through the hospitalization, as things change, as new diagnoses come up, infection and so on and so forth, unsuspected cancer. You've got to add those. And then very, very important at discharge to reassess the patient to see which patients need ongoing prophylaxis after hospital discharge. Studies indicate only 30 to 40% of eligible cancer patients actually receive extended prophylaxis, and this creates a significant gap in care. Ask every question. Complete history taking is non-negotiable. Don't forget, never treat a stranger, never kill a friend. You've got to ask all the questions, and when you know those, of course, you'll protect the patient. Mandatory implementation of evidence-based VTE prophylaxis, in my mind, is one of the biggest missing elements. It's fine to have an algorithm that indicates what to do, but unless it's consistently applied, it's not going to be effective. And there are many nudges to use to help doctors encourage them to do these results, whether it's with peer pressure, whether it's economic incentives, as was done in England at one time. There's various ways to use nudges to get this task done. So, and finally, and thank you very much. I appreciate listening to this lecture, and I'll be happy during the question and answer session to answer any questions. Thank you very much, and I hope you have a wonderful meeting.